So I'm Maria, this is Julie. So we're going to present improving housing and support outcomes for people with physical disabilities. We're going to cover who we are, what was the situation, who we met with, how did we go about addressing the issues, and what's happened as a result. Okay, so as I said, I'm Maria Gregory-Haynes. I'm the Disability Lead Nurse. Debbie Robilliard unfortunately couldn't be with us today. She's the clinical nurse specialist for multiple sclerosis, Parkinson's and motor neurone disease. And we've got Julie Creed, social worker. Sandy in the front, Sandy Farrell is our community support worker. And Dawn Spindler couldn't be with us today. She's our occupational therapist. Okay. And we cover adults with physical disability and sensory impairment from the age of 18 to 65 in the community. So I'll hand over to Julie to explain the situation that we had to address. Okay.
Thank you. Hi. I think I just wanted to say that this situation is one that any of us could find ourselves in. We work with people 18 to 65 who are going out there about their business on a daily basis, as you and I do, who are struck with catastrophic conditions such as strokes, spinal injuries, MS. It can be very sudden, it can be any sort of acquired condition that changes their physical abilities, but also can be catastrophic for the environment that they live in. So for us, it's a real challenge if we come across somebody like that to transform them from the environment they were living in previously to one that suits their new needs and abilities. So it is a resource-intense process. It affects everybody from wider family to financial to work benefits, and can become very complex and very upsetting. There's a lot of loss involved for people in the situation, and it has to be handled very sensitively and in a person-centred fashion. Unfortunately, in States housing, what we came across, and it will come alive when we bring the presentation to you, is that in housing we have the States Housing Authority, which is the original States housing provision. We now have the Guernsey Housing Association, which is really an offshoot of States Housing. And for some unknown reason, they have different ways of working out notice for when you have to quit. So, for example, if we have somebody in a property which is a States Housing property, you're supposed to have 28 days to quit. But then if you're moving into a Guernsey Housing Association, you have to move within a fortnight. And so there's all sorts of different time frames that we came across that we felt we had to address. And really with our the case scenario that we're bringing, we managed to pull together a meeting with both Social Security and housing. The other issue we always have, as a lot of my social work colleagues would know, is that States Housing never provide flooring. So you've got somebody who's not only had a catastrophic incident in their life, they've now got to find new flooring, and that's got to be done in a fortnight frame, and you can't have the keys till the day you sign the tenancy agreement, and all these things just get constantly thrown at somebody in quite a very difficult, compromised position. And for us, we feel a huge sense of responsibility financially, because the flooring can be expensive. It's a vulnerable time of their lives financially, and also the property that they're leaving has to be left in a condition that is acceptable to the housing authority that it belongs to, or even it could be a private landlord. And so if we don't leave it in a suitable condition, they bill the tenant. And we feel responsible for if we're not doing it in a fashion that's acceptable. And understanding tasks that were outside of the job role, that goes on to all sorts of things we've done in our careers as social workers and support workers and physical disability, packing things for people, literally bringing huge sort of resources our team of 5 at one time, perhaps the whole team was there trying to stop somebody having to pay out hundreds of pounds for moving. And it felt all wrong. It just felt this wasn't what we were here for, or what we were being paid to do. But we felt responsible.
Okay, so how did we go about addressing these issues? As Julie said, when we're supporting people with physical disabilities move housing, it's incredibly stressful for them, but also for us. I know I had a few sleepless nights, especially the last person we moved, because you feel for them because you feel that you're the ones responsible, as Julie said. So after the last situation, we got together as a team and just thought, we cannot physically move people ourselves. It's a risk to ourselves with moving and handling. The time strain, it was stressful. We then had to stop what we were doing, other work, to assist one person with moving house, especially if they haven't got any family members or anyone else to help them, and when they've got physical disabilities and pain, they can't physically help themselves. So we initially we said, right, let's get a team of people from Guernsey Housing Association, States Housing, Social Security, Supplementary Benefit, together, our team. Some of the social workers joined us from the social work community team as well. Just get round a table and talk about the issues. I think the breaking point was when you rang up to say, could we hand in the keys the following morning instead of that evening, and a housing officer started saying, but we need the keys now, and so Julie managed to negotiate keeping the keys till the next morning, and that housing officer wasn't even available there when you handed the keys in. So and we thought we'd ended up leaving stuff that the person needed in the house. And also members of the Community Learning Disability team joined us for that first meeting. So initially we just got round the table, expressed what some of the issues were that we had, some of our colleagues have had, equally moving other people, and just looked about how we can go about helping people in the future. So we've established quarterly meetings now to help change policies and procedures. It came at good timing because there was a new head of housing, Lynn McLagan. She's also worked in health, so she's got a good understanding as well of health. So it came good to change policies. So out of those meetings, we've improved and got more effective working relationships and communications. We've met the people we're communicating with now. When you pick up the phone, they know us, we know them, who we can talk to. We've also, from Supplementary Benefit, they've established that there is a grant for people that are already on Supplementary Benefit to actually help with the actual removals cost, not the packing, but at least it's something, the removals cost. But again, it's as long as they meet the medical criteria of Supplementary Benefit and that they haven't got any other family and friends to help them. It was also good they were changing policies with housing and Supplementary Benefit with the new income support system. So we heard it firsthand from them. So again, we knew that, and we were able to say, well, actually, what about people with cognitive impairments? If they get this letter, it's going to cause worry to them. So they were then able to say to us, well, actually, if you have a look at our letter first, we were then aware what they were then going to send to people, because a couple of weeks ago we got several phone calls, didn't we, asking us for help to fill out the forms that people have had, or panicking that they didn't understand the new income support and worried that they were having to pay more rent. So at least we knew about that information before it came, so we could support them with it. Okay, so improved communication. We've developed a shared understanding of the needs and complexities associated with accommodation and individuals with physical disability and other vulnerable groups. So again, they're aware of our issues. It's not just, that's not our problem, they're moving. It's actually States of Guernsey, because our time is valuable. So it got them understanding that, okay, they don't want to make a loss on the property because they've given us extra time. But on the other hand, we shouldn't have our staff physically moving people, because again, it's taking us away from what we should be doing, and time is valuable. And again, also with adaptations for the occupational therapist, we've discussed the best ways to go about that, and we're setting up separate meetings to discuss that and how we can work together on it. Okay. And as I said, opportunity to impart knowledge to housing providers regarding any challenges that we have in raising the awareness. Okay, so Julie's going to do the case study that that nearly sent us over the edge.
I think this was the case that we presented. We did present it to housing on that day, and I think it caught them because they could picture what was going on and how difficult it had been for everybody involved. And this lady was known to us for many years. The outcome happened this year, so that's 8 years of working with her. This was the third move we'd done with her as her health had deteriorated. We'd gone from a family home because she had 2 young children when we first met her, well, say young in their young teens. Then that was in an upstairs maisonette. She had external concrete steps to negotiate, which were extremely dangerous for her, so we went down to a normal 3-bed family house, and then the second move was to a 1-bed as her children had left home, and then the final move was into extra care housing. She has mental health issues, she has real physical disabilities as well. She's got poor balance, she walks with a 4-wheeler walk frame, she can't stand for more than a few moments at a time, and needs constant care, and is very, very vulnerable. And over the last 8 years, she deteriorated to reach the final decision that she wasn't able to live alone. The family didn't even ring, they don't even know that she's moved. She has 5 children. There's not one of them knows where she is or has rung to see where she is, and she's settled where she is now. So we became very, very important to her as her support network, and that's just how sometimes it goes. Yeah, she'd had a heart attack in the last 3 years, and that was just one of the previous properties. Sorry, I'm going ahead of myself. We've had various interventions with regards to finances. In her isolation, she used online buying of stuff and retail stuff. So it was really complex. We knew there was no money. We knew that she needed our help. And she was very poorly, and she was deteriorating. She was having massive input with constant call-outs to the GP, the ambulance was going, rapid response were involved, the carers were visiting several times a day. Many times it felt this was because of her isolation, and because her health condition was managed very carefully by her GP. Well, I mean, it was managed, but she wasn't managing it, which is why there was a lot of carers. Sorry. Yes, so it was a labour-intensive existence for her to keep her, I can't even say happy because she wasn't, but to keep her in a manner that was relatively safe at that given time. Yes, this was what this lady had lost. Her driving was hugely important to her. She just loved going out, meeting people. Well, she didn't meet anybody. She used to go out and talk to people and go to the charity shops on the bridge. All the interventions. And I don't think anybody, she felt, understood how she was feeling. And she applied for extra care housing. And that was what was the game turner for her. I think we sat with her for a long time. I mean, I think she felt that living where she was, going into extra housing was actually a negative step. So we took a long time to persuade her that it was a positive one. We did that by initially taking her in there for respite. And that was a good experience for her. And then earlier, at the end of last year, she had a placement in extra care housing at the Nouvelle Maritaine. And the outcomes of that have been absolutely incredible and changing for all of us as a service, because we don't hear from her anymore.
We've discharged her now.
It really is as simple as that. I mean, it meets all her needs. She has somebody around all the time, you know, even if it's just seeing people.
It's knowing there's someone around as well if she needs them.
Yeah. And in fact, the call-outs that they thought they'd have to do for her, even within extra care housing, are nowhere near as many as we initially thought. Because as the reinsurance has come through to her that there is people there readily available, she no longer calls them. She does more than she ever thought she could and would. She has the day centre downstairs at the Willows, which is absolutely part of her family now. The family still don't know where she is, or if they do, they're not saying, and they don't visit. We see her once in a while, and she's off now on the Jombulance holiday, which is the first holiday at 62 that she's ever had. And we never thought that we would reach a situation like that. So for all the work and all the stress and all the sort of wondering how on earth we're going to pay for this or where the money's going to come from, and we used charities, we've used everybody that we could think of to get her to where she is today, it's been a positive outcome. But we had to relay that process through to States Housing and Social Security just to try and let them know that we can't do that every week of the year, and there's potential for that when people need to move on. You know, we just couldn't work with everybody that we get referred if we had a lot of people in her position. And of course, for the taxpayer, I can imagine there's a reduction in expense as well in an overall sort of sense, because she doesn't need the resources that she did before.
I don't think she's had any A&E admissions either since she moved Julie as well.
No. And financially, she's definitely more stable. She knows what she's got to pay. She knows her outcomes. As I said, her general well-being's improved. And she has blossomed. And if we can, you know, discharge her from our caseload, that's for us a job well done.
Success. Yeah. At one stage we didn't think she was going to get into into extra care, because when she went respite she tried too hard and they thought her needs were too high. So because she thought that she needed more care and that would help her get in, but so we had a word with her and yeah. She met the criteria. Okay, so case study 2. This is about a young lady. She was in her early 20s at the time. She's had a neurological condition from birth and complex health needs. I knew of her, I think Sarah knew her as well from Children's Services many years ago, but on transition she kind of slipped through the net because her parents were very private family, doing the care. They'd always cared for her at home, always looked after, didn't want any intervention. She lived in a States house. When she went to school, her care needs seemed to be adequately met. She went to Interwork, so Ron, I think you were Interwork at the time. But no one had actually been into the house. So we'd never, as in adult services, we hadn't. Children's Services had many years ago when she was a young child, but no one had been in the house probably for about 15 years, no professionals. Okay, so she lived in a States house. with her parents and younger sister, all of whom had their own health needs, mental health and physical health needs. Okay. At the time, as I say, no community healthcare professionals were involved or had visited the home, and we had offered support, but the family had declined it. The mother, who was her main carer, and she was very close to her family, never had been anywhere else but with her family. They never complained about anything or never asked for anything. Then in January 2012, her mother took seriously ill and was admitted to ICU, so prolonged hospital admission. Initially, she wasn't expected to live, and I got a call from the older sister who wasn't living in the home saying, could we help? Because obviously the daughter was totally reliant on her mother, had never been anywhere. So initially we were thinking of respite, but again, the young lady was very nervous, had never been staying with anyone else. They didn't expect her mother to pull through, so they needed to be together as a close family unit. So on referral, I visited the property with an occupational therapist at the time. The property was totally unsuitable. Upstairs to the bedroom, the young lady was a totally dependent wheelchair user, couldn't transfer herself, and what her mother had been doing. There was an old stair lift in the property, and the mum had actually been physically lifting her daughter onto the stair lift, but ended up with a ruptured hernia from doing that. So we went in, we were faced with a lot of clutter, the stairs very steep, you could barely kind of walk past the stair lift to get to the top of the stairs. And we just thought, oh my goodness, how can we manage this? Obviously the family were very distraught because of the situation and the mother being so ill. Okay. As I say, the father had his own physical health needs, and the younger sister had mental health needs. Okay, so we did think about emergency respite, but we just thought, no, she was just so upset and wanted to be with her family. So just how can we manage this? We were looking, can we move a bed downstairs? But the amount of stuff downstairs, we just couldn't do that. Okay, so we joint work with the occupational therapist. We had the health and safety officer around as well, States Housing, Social Security Department, and a package of care from community. The individual was able to remain at home with the family. That was a late night. I think we were at the house till about 9 o'clock that night trying to work out how we could help. Initially we had the older sister coming to help in the evenings until we could get all the moving and handling plans in place to help. We then, obviously when we were looking at hoists and things, they discovered there was asbestos and everything. They didn't even have hot water in the house. To get hot water they had to light the fire, and so we met with housing and said, well, this is 2012, how come they haven't? But I think maybe there was literacy problems, and the family didn't respond to letters that housing had put through the door saying they were going to upgrade the property. So no one followed it up. There was old tracking devices for ceiling track hoists upstairs and also in the bathroom, but she couldn't access the bathroom at all. But the equipment was useless, didn't work, couldn't get her in the bathroom. With obviously getting equipment and everything into the house, we managed to keep her at the property. Risk assessments, moving and handling equipment, care plans and moving and handling plans, and a community care package. So I didn't think we'd get there, but we did. However, so the longer term involvement, obviously it wasn't sustainable for her to remain at home, or the family to remain in that situation. Thankfully the mother recovered, but obviously could not physically manage caring for her daughter any longer. Otherwise she wouldn't be alive today if she carried on doing what she did. The father was very precious about staying in the home. He was quite embarrassed about the situation, but he didn't want any help. But we set up kind of family meetings, the occupational therapist and myself, and we managed to persuade them to meet with housing with us. And as it happened, that's when they were just building the properties down at Rue Sarchet and the Boet. They were able to, Guernsey Housing Association, we were able to offer, well, how about we build a purpose-built house? Because obviously there was another daughter at home, the young lady with physical disabilities, as well as the parents, and all had health needs. So we built, we just built the house. No, we were involved with the planning and everything, but the father was, nope, don't want to move, can't we adapt this house and things? And, in the end we said, no, we can't. It was either that they needed to move or that the young lady would have to move out of the house to have the care. He actually kind of came round to it. He got very excited. He said, well, as long as I have a garden that's low maintenance, yep, you can have that. As long as I can fit my, double cooker in, yep, you can have that. So we were able to then bring him round. And then actually when the property was nearly finished, we took them to visit, and he was so excited. And obviously the two girls used to share a room, and for them to be able to have their own room was amazing. Okay, so we met with housing, social security, looked at adapting it to meet their needs, opportunity with Guernsey Housing Association to build accessible purpose-built, and joint working with OT, myself, Guernsey Housing and the project manager. So it took about 18 months in all. Okay, so the outcomes now when they moved, they've now in a purpose-built accessible property. They've got an increase in their standard of living, safer environment for all of them, as plus the carers that are going in. Improved physical and mental health outcomes for all the family members. To actually see the difference with them is amazing. Increase in confidence of the individual, improved social and well-being for all. Oops, and that's it. So it was quite amazing to see the difference to have, accessible housing for this whole family. It wasn't just the individual. So, okay, thank you.
Any questions, anybody, for either Maria or Julie?
I can resonate with you. Community social. We have similar problems in terms of moving and packing. I'm just wondering whether housing, if it's housing or housing association, the use of volunteers, whether volunteers could come and help people, because we have older people who have to move into care, and similarly, clearing properties and things like that is an issue. And I agree, it's not a task for social workers, although I've done it, or for support workers, and they've done it. Whether volunteers, because it's an issue, and I don't know what you managed to negotiate with housing association, but for them to be a bit more flexible and a bit more helpful, really.
Housing themselves don't have any volunteers, and it's not their area to be concerned in, but they
were their properties, isn't it?
I know, but they were what they've got, because one of the issues we had was with flooring, and it used to be that from one property to the next they used to rip up all the carpet, and even if there was laminate flooring, they used to take that out. They have now got, as soon as the person gives their notice in, the housing inspector will go round. If the flooring is suitable, they'll allow the person to leave it there, so that cuts costs down for both parties. Obviously, if the person's got pets or the stains on the carpet and everything, it's not appropriate, but they do now try and keep some of the flooring down for the individual. Lynn McLagan is looking at changing the policy as well. They're looking at maybe doing a grant for flooring. We asked last week, so they haven't got that in place yet, but that's something they're looking at, because somewhere that she visited in the UK, the housing department actually has a grant for people who actually don't have any money to get flooring. We've had charities, haven't we? Like this last case study that I spoke about, that we got a charity to fund the flooring, for them. The father actually laid the flooring, and the charity funded for the wooden flooring to go down. But to actually physically move someone, we've got supplementary, if someone is on benefits, that will do a grant if they haven't got the money to actually do the move. But it's still
Not
the
the packing.
It's not the packing. It's still a problem with the packing. But maybe that's something we can look into. Maybe the volunteer site is that something that we can look at. It's really difficult because the lady that Julie talked about, everything had a story, so she wouldn't get rid of anything. It's something that when she went to Brighton in 1979 and little glass jar of sand, and
That's the issue we have with hoarders.
Yes.
That's another issue. Regardless of this, we've got hundreds of them.
Yes, yeah.
And sort of stuff, and that's another issue.
It is, and it is, and again, if one of our previous community support workers had helped a lady move in between, and then they then said, they threw out, she's the service user might accuse them of throwing out stuff that I didn't want thrown out and things. So we have to be really careful. I know I was up in, we'd forgotten there was a loft space in this house, and I'd gone up into the loft and thought, oh no, there's boxes of Christmas decorations. And only a few decorations, she said, up there. Boxes and boxes I pulled down. Sorry?
4 chairs.
4 chairs up there as well, and there was loads of wrapping paper up there, and even the crease work she wanted to keep. And so that's something we still have to work on is the packing, because again, insurance wise.
So, some of our home helps, if they're already involved, or some of our senior carers, they have if people have to move into care.
Yeah.
They have been able to do that as part of their role, but that's if they're already.
Yeah, and
there is a cost.
we had for this lady as well. The home help had kind of befriended her as well, and actually cleaned the place. Was spotless. The next day over the weekend, she popped in and actually cleaned the place out. And that wasn't her role. She did it in her own time, but because there was no one else to do it. And the person herself couldn't. She was in so much pain that even just standing up was a problem. You're welcome to come to our next quarterly meeting, Margaret. I'll send you the invite. Okay, with housing. So again, we meet with housing, and we talk about things about how we can have a resolution to some of the problems we have. Okay, any other questions?
Hello, thank you very much for your presentations. They were really interesting. I just wondered, from the 2 case studies and the work you've been doing, what you've learned to make changes for other service users in the future, and how you've implemented that.
What we've learned about how much stuff people have. I think it's about that, giving people an understanding. Like the case study I discussed, if I took it at face value, the father saying, no, definitely want to move, it would have made our lives a lot easier. So, okay, that's fine, that's your choice. But actually, persevering and working with him in very much a person-centred way. So it wasn't just the individual, it's how important it is to work with the family as well in that situation. And also, I suppose what we've learned is the barrier that unsuitable housing has on people, and the impact on their health need. But actually, if they've moved into accessible properties or have got a support package, it improves their quality of life tremendously. Yeah. So a lot of our work is because of the barriers in society rather than the needs of the individual. Okay.
You were saying that the second case that you talked about was a lady who was obviously in her early 20s but hadn't, like most of our support came from her family. So when she transitioned from children to adult services, is there a criteria for you to investigate things then?
Yeah.
Would that be something going forward or something?
At the time, we were involved with transition meetings with the school, and met the the mother at the school, through the school, and again offered to do home visits. So what we do now, you know, we still offer to do home visits so that you can, because it really in a formal meeting, it's overwhelming for the family and things. So we normally arrange to meet separately with the family or the main carer to actually establish what the needs of the individual is. But obviously in this situation, they clearly didn't want to meet with us. You know, now we'll meet with people to build up a rapport outside of the home situation. So at the office, we might meet in the interview room rather than going home, and it's building up that relationship with them before you actually go to the home situation. But yeah, we were very shocked when we visited this house, and she hadn't been able to access the bathroom for many years as well. It's very sad. But her health needs, yeah, you know, all round have improved by the input we're giving them. Yeah. But again, we didn't take it for that case, for the community care package. It was like, no, you know, we haven't got the right equipment in place, we're not able to do that. But we worked around doing that, you know, because I think if she'd gone into a respite situation, that would have been stressful for all of them. But she goes to respite now, and she enjoys that because, yeah, she's now gradually got used to it and built up her confidence. Okay, but she's like a changed person, yeah.
Sorry, just to say something, what strikes me is that we hear so much about multidisciplinary teams not working. And I think what that's shown from today, for me anyway, is that benefit, you've got 5 people that are all different professions who've worked together but have developed that further into joint working with your other organisations to bring results. And I think that's probably something that a lot of areas could learn. So congratulations on that.
Thank you. Okay, any more questions? No.
So I'm going to be talking about the health needs of people with learning disabilities in a community setting. Before I start, I just want to say that some of my stats are already out of date because of a review that came out last week. So I'll be referring to my notes quite a lot for the updated stuff. So it's really difficult to know the prevalence of learning disabilities. But we think there's roughly around 145,000 adults with severe and profound learning disabilities, or this is in the UK, 1.2 million people with mild and moderate learning disabilities, which equates to around 1 in 50 adults in the UK. We know these statistics are slightly out of date already. We don't do many censuses, unfortunately, with the prevalence of learning disabilities. So in Guernsey, that means we think there's approximately 250 adults with a learning disability. So that's not looking at children, that is purely adults with a learning disability. The reason we have to say it's approximate is because some people with mild learning disabilities go undiagnosed or they aren't known to services. So we have to say it's an approximate. We knew in around 2008 that this was set to rise by 1% every year, and it would have risen by 10% by 2020. So we know that 250 is probably not exactly in date, and the figures before are definitely out of date. So what are the main causes of learning disabilities? So we have genetics. The top one is Down syndrome, that most people have heard of, and then we've also got Edwards syndrome and Patau's. So those are the top 3 genetic disorders. And then you also have trauma before, at or after birth, premature birth, lack of oxygen during birth, mother being ill during pregnancy, childhood illnesses and seizures during childhood. Those are all the main causes of learning disabilities. So the health needs. People with learning disabilities have more unmet health needs than the general population. We have said this so many times now. It's been around 10 years since Death by Indifference was released by MenCap, 10 years since the Michael report. We've had 74 deaths and counting, and now, again with the Learning Disability Mortality Review 10 years later, we're still saying the same thing. There is still inequality within healthcare for people with learning disabilities. They have more unmet health needs but go to the hospitals and have appointments less than the general population. So what are the mortality rates within learning disabilities? Men with learning disabilities, according to CIPLD, died 13 years younger than the general population, and women would have died 20 years younger than the general population. Now, as of last week, that's completely changed. So now we're actually saying that women will die on an average 29 years younger than the general population, and men will die on average 23 years younger than the general population. So that's actually a big difference, and CIPOLD only came out a couple of years ago. So we thought we were getting better, we thought the age gap was reducing, and actually we've just been proved completely wrong. It's gotten worse again.
Jo, do you
Yep.
think it's actually got worse, or do you think there's something about it hasn't been, the learning disability hasn't been recognised?
I don't know, it's really awkward because as I go through this, I'll show you some of the other statistics, because even MenCap released things in 2018 and that's been proved completely wrong again. So I don't really know what's going on, but some of the stats are just all over the place at the moment. I'm just going to go back to this one. So, men in the general population will usually die at the age of 78, whereas men with a learning disability will die at 65. Women will usually live to 83, but women with learning disabilities will die at 63. This is what some of the research is telling us. So you can see quite clearly on the graph the differences and the inequality right there.
Can I ask a question?
Yeah, go for it.
Have you looked at how that might be skewed by the fact that people with more complex and profound...
I'll go through those in a minute. I've got all that data. I'm prepared. So, this is exactly what you were asking. So, people with mild learning disabilities will usually die at 67.5. With moderate, 64, severe, 59, and profound and multiple, they will die roughly at 46. Now, again, the Learning Disability Mortality Review has changed those statistics. So people with mild learning disabilities, they are saying will on average live to 63. Moderate will live to 62. Severe learning disabilities, 54. And multiple and profound, 41. So these stats on the screen came out by MenCap earlier this year. So again, we don't really know what we're looking at still, but we do know there is a big difference between learning disabilities and the general population. Does that answer your question, Glenda? So the common health problems in learning disabilities. So they will include mental health problems, visual impairments, so you're more likely to have, 40% are more likely to have hearing impairments as well, weight problems. So it's interesting because we always think people with learning disabilities are more likely to be obese. But actually, the more severe the learning disability, the more likely is someone to be underweight. Unhealthy teeth and gums, so 1 in 3 people with learning disability want to have unhealthy teeth and gums. Dementia, Down syndrome has a direct link to dementia, so you're more likely to have dementia. And respiratory diseases. Now, the mortality review has just said that the main causes of death were respiratory disease at 31%, circulatory diseases at 16%, and cancer at 10% for people with learning disabilities. There's significant focus on sepsis. That's apparently really high in learning disabilities at the moment. Pneumonia, aspiration pneumonia, and constipation are all leading causes. And men are more likely to die from circulatory disease and women from cancer in learning disabilities. So how in Guernsey do we try and counteract those health inequalities? Well, we've got health checks which started to be funded in 2016 by Social Security if you are in receipt of supplementary benefit and have a diagnosed learning disability. So this should be offered once a year by a GP practice. They're still trying to get into the swing of things. So basically you have an appointment with your nurse and they'll try and take bloods, weight, height, all your basic checks. And then around a week later, once those results from the blood test are back, they will have a double appointment with the GP and have a comprehensive health check done to try and highlight any unmet health needs. Now in the UK, the first health check people have are highlighting unmet health needs. But the one the year later is highlighting even more because they've got that proper baseline. So these are proven to work. They've been in the UK a lot longer than they have in Guernsey. Over here, we are recommending the Cardiff Health Check. So this is well known in the UK. It's a really good check, and it goes for an awful lot. They're available on the internet as well, so you can see what sort of health checks should be happening. Within adult disability as well, we also offer health action plans. So health action plans are documents that help you record what health needs you have, when you should have appointments, what the national standards are, and what follow-up action should be needed. So they are live documents, they should be constantly in use, and everyone with a learning disability should be offered a health action plan. They don't need to accept, but they should at least be offered one. We have two in Guernsey. We have the female and the male version, which are offered to anyone if they want one. Also, we do advocate for reasonable adjustments for health appointments. So we like to offer the first or the last appointment, and that's usually because waiting times, it's better. You don't have to wait as long. The waiting rooms aren't as busy, it's not as chaotic, so it usually works better. Offer a double appointment. 10 minutes of a GP doesn't really last that long when you've got communication problems, so you need to think about how you're going to make that more accessible. Accessible information. People with learning disabilities are unlikely to be able to read or write, so handing them a nice written leaflet isn't going to work very well. And a quiet place to wait. So even if there's a room off the corridor that people can wait in to take them away from the busy environment, that's fabulous. So in the learning and mortality review, they actually said some problems they were coming across were delays in treatment, gaps in service provision, organisational dysfunction and neglect or abuse. So that's where these reasonable adjustments really weren't looked at and weren't considered to how to make it easier. So as I've already said, Deaf by Indifference was released 10 years ago now, and 74 Deafs and Counting was also released a while ago. So these documents, they go through what I've just said, what reasonable adjustments should be made. They go through case studies of needless deaths of people with learning disabilities. And they are quite hard-hitting documents if you ever have time to read at least some of the case studies. And then again, Learning Disability Mortality Review, which was released a week ago. It said exactly the same as Deaf by Indifference, Michael Review, 74 Deafs and Counting. There is no new information there. It's just we need to be better at actually implementing it and following the advice. The top three learning were interagency collaboration, including communication. So as highlighted by Maria and Julie, talking to people, multidisciplinary working, those are really, really important. Awareness of needs of people with learning disability, more people going to LD awareness, understanding how to communicate with people, reasonable adjustments, health needs, people need to be more aware. And finally, understanding and applications of the Mental Capacity Act. I know we don't have Mental Capacity Act in Guernsey yet, it's apparently still being written, but we should be following best practice, and that's following the UK version. I haven't included anything really about hospital care today because that's a whole different subject. So we're going to be going through more about hospital care, such as the Treat Me Well campaign, which is MenCap has released. In the, I think it's the September one, is it, Vicky?
It is, yeah.
So we're going to be going through hospital passports, the Treat Me Well campaign and that in the September, Safer Every Day, and also Learning Disability Week, which is in June this year. So we'll be doing lots of different workshops on different aspects of that. And that's me done.
Any questions?
I know it's a very basic question, but I wanted, do you have a definition of a learning disability? Because we in adult community often find adults who have slipped through the net,
Yeah.
who we believe have a learning disability which has been undiagnosed, unrecognised,
Yep.
and we have tried to put people forward to what was the learning disability register, which I believe may not exist now, and even
We do
because
still
I
have
know, well, they're
criteria.
better placed with you. Well, no, they're not, because they have got a learning disability, and I just wanted to ask you about that. I know it's an awful
Yeah.
question, but if
So
you-
there is a process for being diagnosed with a learning disability. We do have a panel which would review and assess. The criteria is something like having an IQ below 70, have to have happened before adulthood, lasting effect on development and impacts on the way you learn and develop and you use everyday skills. That's it. Well done, Maria. I got the others. I think it's really difficult because if someone has, functioned up until, 50, 60 years old and hasn't needed any specialist support, you have to take it on a case-by-case example and say, what has changed in this person's life? Is it the learning disability or is it something completely different from the learning disability?
And that's what we've been told. Oh, well, they've managed. They haven't managed. That's why they've come to our attention. They're hoarders. They've
But
no
what
idea about handling money.
What we look at is does it require specialist learning disability support or is it some other type of support that they require? It's that really fine line of, is it learning disability specialist? Is it mental health specialist? Is it community support? Where will they fit? It's not always an easy question. It has to be case by case. Anyone else?
Jo, thank you very much. That was, again, really interesting. What are the things that we really need to do in Guernsey to make the difference to people with learning disabilities and to actually get some more equity with how long people live? I know that's a really big question, but if you could wave a wand.
I think it's just more learning disability awareness, how to communicate with someone with learning disability, how to treat them. I think there is still that stigma and, oh look, they're 50. Haven't they done well? They've lived a really great life. And it's trying to change.
It's the learning disability as well, isn't it?
Yeah.
It's seeing the individual.
Yeah.
Not seeing the disability first.
It's interesting, I've just done some training last week and I was talking about annual health checks and I said the first one will show up health inequalities, the second one will show up more. And a couple of staff went, oh, we've actually supported people to a few of those and they haven't highlighted any unmet health needs. So I don't know if that shows actually in Guernsey, because people go to the doctors a lot, if they're in our accommodation service for sure, are we already capturing them without the annual health checks? I think it'd be quite interesting to look at that.
Services we say that we've got exactly. Because it costs to go to the doctor, that's why they're not accessing
Yeah.
Do we know what the Guernsey mortality rates are then?
No, we don't. It would be actually really interesting. It would be a good research. Because I don't know if we'd be slightly higher.
I think it'd be really interesting to know.
Yeah.
We certainly have, the ones of us who've been in the services for a fair while can definitely recall some deaths that would definitely meet the criteria of death by indifference, without a doubt, who have not had adequate support, who we have tried in our roles to champion and get them the correct support. And unfortunately, often what happens is that differential diagnosis and diagnostic overshadowing of the learning disability being the problem, when actually they could be sat with a real health need that's just not being addressed. And don't get me on that side because I am extremely passionate.
Or could be put down as challenging behaviour when they've got paid.
Yeah, that's when I say people need a greater understanding. It's, don't just look at challenging behaviour and say they've got challenging behaviour. Actually, why have they got challenging behaviour? What is the cause? Could it be an unmet health need?
We've had people who have been absolutely wonderful, lovely and calm individuals till they're, 60 years of age. Then all of a sudden their behaviours change, but apparently that's because they've always been challenging. Hang on a minute, we've just had them living for 60 years and been absolutely wonderful citizens within the community. And then that person drops dead.
Yeah.
And then they find they're riddled with cancer that we didn't spot. We've had those. Anyway, don't get me on that. We're going to end on a more positive note.
One of the other things that they do have in the UK, or they did implement in the UK, is a flagging system within the patient records. And they've got that on track. It'd be great to have that on track. So that
we will make note of that because there are things happening afoot with track. Thank you, Jo. So, finally, to a success story, just to end on a hopefully slightly more positive note, because that's a little kind of gets my blood pressure raising in those topics that we've just been listening to. But we're going to talk about a service user very close to my heart, who I've worked with since 1997. And I'm not going to say any more, but hopefully you'll see the difference that has eventually been made as we've responded to that person's needs. Over to Derek.
Yes, I'm David. I'm a support worker, and I was lucky enough to sort of be part of Sarah's life and support her in the transition from this residential home, which was probably, she was probably classed as challenging as well, in a way. I remember when I first met Sarah, I wasn't working in the home, I was working for another home, and I was doing post or dropping something down there. And I went into this home, Sunnybrook it was called at the time, and I walked in, and this young lady was behind a gate, a door that was locked, a half door if you like, and she was locked behind it, and her hand was out, and we just walked past her. And like everyone else, I'd done that because I didn't know what she was trying to communicate. I didn't know she was trying to communicate with me. I just done what they were doing. It was, not until a couple of years after that that I actually transferred down to Sunnybrook to work. And through the induction, I was watching how people were interacting with her, how people were, communicating with her. And some examples were like she would go and get a pair of shoes, and she'd give the person a pair of shoes, and staff would put them down and say, no, we can't do that just now because unfortunately in a home you'll probably run into a routine, and you don't always have the time to sort of need to do that. It could be possibly the vehicle's gone, or it's a non-driver on, or somebody that's not confident working with her. And you would watch these, and then there was once a week her parents would come, and they would come for a visit. Sarah would probably be in the kitchen, the dining room area, so it was in the communal room, and people were still accessing that room, so her staff's attention could be taken off of what was happening, and Sarah's attention taken off because she sees staff and stuff. Her mum and dad would come for a visit, and they would probably last about 10, 15 minutes maximum, if that, and she would give them the shoes, and she would rush off, and and that would be it. She'd be gone, and she'd be going to bed, and that would be her for the evening. On other occasions, if she didn't get out the vehicle and stuff like that, she would eventually she would either hit out another service user, or she'd hit out the staff. Which would then result in an incident report. And in some cases, she would go off to bed in the afternoon, about 2 or 3 o'clock, and that would be her to the next morning. And nobody would know that she was upstairs, so she was in bed, and she was just left, depending on what staff was on. It was just like I finished my induction, I started working with her. I then sort of realised that when she came to me with her shoes, rather than put them back down, I put them on her feet. To let her know that I was hearing what she was saying, that she wanted to go out. If the van wasn't there, I couldn't obviously take her because it wasn't there, if it was used for something else. I explained that to her. She would see that the van was not there because I'd opened the curtain, and she could see the van's not there. I would then go about my normal jobs, and she would follow me around, and because she knew that I was listening to her, and she was going to go out because her shoes were on her feet. And we continued doing stuff like that, and eventually she would go out, but we still had some behaviours because the vehicle wasn't there, staff's confidence and stuff like that. We then got the PBS team involved, and we done lots of charts, and we got lots of feedback from incidents that were happening and what was causing incidents, whether it be menstrual cycles and all these sort of stuff. So we had everything down, which gave us all these kind of answers, if you like. And we started to sort of get Sarah back involved in the community. And being part of that, like going to the shops, doing stuff even as much as actually going to the doctors. I remember taking her to the doctors, and the doctor opened the door and shouted her name out confusingly because she'd never been into the doctor's surgery for her own appointment. She was always coming to the house. So there was there was a lot of stuff like that happening, and it was starting to change for her. And after all the charts and graphs and stuff we got from BPS and stuff like that, it actually turned out that it was the environment that was wrong for her. It wasn't right for her. She just needed to be somewhere where it was just for herself, which we did. And with the support from senior staff and management, I don't know if you guys were involved as well, but they managed to sort of, get her own place, and that only happened as well because of the determination of the staff team and the support from her mum and dad. Her mum and dad, I think, have been waiting for this to happen for about 21 years or something like this, so it's a long time. And many a times they'd been let down because they were saying that it was going to happen and it didn't happen. It was going to happen, it didn't happen. So they were a bit like, yeah, again, sort of style. And it did, it happened. And, you know, it's like, it's transformed her life and it's transformed their life as well. We have, after the first initial time of getting there, we had the initial settling period. Sarah soon established who she wanted to be working with her in her house. It's her house. We managed to sort of support her on a one-to-one basis there. After a bit, we managed to sort of watch her money, save her money up. She managed to sort of buy herself a new car. So she's got a car, so she can access the community anytime she wants. The most for me, the most touching moment is the fact that our mum and dad would come and she will help make a cup of tea for them. They'll stay for up to 2 hours. They get their shoes off, they sit with their feet up and interact with her. She engages with them. She's smiling a lot more. Her brothers, who I don't think had ever been to Sunnybrook, had been to her house, bought her furniture, and it's as if she's been brought back into a family. And it's actually very nice to see. And the fact that this young lady, we've run around and bite, whatever, she has young nephews that come to visit and she interacts with them and they run around her flat and she enjoys that interaction from them. And she is, where am I there? Yeah. The incident reports that we had for Sarah are pretty much stopped now, whereas before we were probably having around
500 per year, at least, of incidents of violence.
Yeah.
Say that.
Yeah. Thank you. So, saying that, and Sarah's been there since 2015, and I'd say we've had about
2 or 3 of violence and aggression in that time. Really dropped.
In a period since 2015, I'd say it proves that sometimes when you look at things, maybe the environment is the wrong environment for a service user, and actually getting them out and into the community and reintegrating, if you want to use that word. She goes out, she has control of her own finances to a way. She will go to the bank, she will withdraw the money from the bank, she will go to the shops, she will do the shopping, she helps in the house. She's so much happier in her way. She's engaging with the public and with staff that actually work with her. And she's just a happy person, as you can see there, out in the community, enjoying the sunshine just like everyone else, and not having to be restricted to a home environment where you're sharing, the vehicles and stuff. It's just an insight of how life can change for an individual. And that is my little success story. I'm just glad you listened to it.